Welcome back to another edition of the Hart2Heart Podcast. My guest today is Dr. Yosef. He's a psychiatrist who specializes in getting people off of psychiatric medication. So I'm really excited to chat with you today, brother. So welcome to the show.
Hey, thanks for having me, Mike.
So, before I start firing some questions at you there, maybe you can give the audience a little bit of a brief background about yourself.
Sure, yeah. So I'm originally from Australia, and I guess people always, they want to know this. How'd you get into psychiatry? So I was really into self-help. I like self-help. I like philosophy, all that kind of stuff. Mostly for myself, how do I have better relationships? How do I find fulfilling work? That kind of stuff. And so that was a big interest of mine. And I ended up kind of falling into medicine. I went to like a pretty nice academic school, and everyone sort of was like a lawyer, a dentist, or a doctor. That was sort of like the path. And I ended up in medicine. And then when I was there, I was just like, you know what? I can't really see myself doing any of these things, but I still loved self-help. I loved the idea of learning about life and finding happiness. And so I said, well, psychiatry is kind of like that. Maybe I could, merge this medicine thing with psychiatry, and I could build out a career where I kind of help people live more fulfilling lives. And I said, yeah, that kind of fits. And then I ended up going to the US for my training, and pretty quickly into that, I noticed that it was a shit show. It's an absolute dumpster fire there. And sort of like deep in my gut, I was looking around at what was happening in psychiatry, and none of it made sense. We would have people come in, people who were just like depressed and anxious, and we'd be seeing them in these 20-minute visits, and we would be diagnosing them based on checklists of symptoms. We're not really taking much time to get to know what's going on with the person. And pretty much the visits just involved, hey, we can put you on this med, or we'll up the dose, or we'll lower the dose. And that was it. And I guess intuitively at the time, I was like, there's something really wrong with this, because it doesn't make sense that you can really like help something unless you understand like the root cause. And for me, my leaning was that, hey, there's a lot of root causes in life, life stresses, relationships, work, all that kind of stuff. But the kind of the playbook in psychiatry is, it's probably biological diseases, and just look at this checklist from the DSM, and that's what's going on. And I thought that was crap, but no one was saying anything, Mike. No one was saying anything about it. It was just like, this is just kind of the way it is. These drugs, they're evidence-based. The FDA says they're safe. It's all good. And I would bring these things up, and people would be like, no, Yosef, these drugs are safe and effective. And I always get this sort of look when I'm just like, guys, I really think that there's something not right about what we're doing here. And they'd be like, no, it's totally okay. Anyway, so I had this. So I'm going through all of this at the time, and I'm a young man. So, I was like kind of 25 or something like that. I'm like, what the hell do I know? I don't know anything. I'm a resident trainee right now. Why am I going to say, oh, my gut feels like there's something wrong about this? Even though I was seeing the fact that these drugs weren't working, and people were getting side effects, and they were wearing off, and it was just turning out really bad for some people. I said, well, I need to learn about clinical research, because these guys probably know something I don't know. And so I ended up doing a fellowship in psychiatric clinical trial design, and I went and worked for Johnson & Johnson. And then after working for Johnson & Johnson, I went to the FDA, and then I did what so many people do, which is bullshit, but I did it anyway. And RFK is going to shut this down, I hope, today when it gets confirmed, is I went from FDA back into industry. Yeah. So I did that revolving door. I went from the FDA to industry, because they love it when you do that, because you know how FDA thinks. And I worked in the pharmaceutical industry. And from looking at all of that, I noticed like several things about psychiatry. One, that the evidence base was just shit. Like, we would tell people the drugs were safe and effective, but honestly, we were studying them for about 3 months. And then they're like, oh, well, but we do an open label extension afterwards. We look at them for 1 year. So, what happens is there's like placebo, and then there's like active, and that goes for 3 months. And then the placebo group goes away. And then they just follow the people on the drug for another year. And pretty much they're just looking to see if someone like turns blue or has some crazy side effect that has delayed onset. But really, in terms of efficacy, does this drug work? It was 3 months. And I was just like, this is crazy. We're putting people on these drugs for multiple years. We're telling them they're safe and effective when we study them for 3 months. And as I'm kind of learning all of this, I have a private practice on the side. I'm doing some moonlighting, and I'm having people come to me who are, one, they're just like, this drug isn't doing anything. I feel flat. I have no motivation. I'm fully maxed out on this drug and like multiple others. And then they couldn't get off them. And so I'm also seeing this other side of like, what happens to these people after they stay on drugs for decades? And that's when I realized I was like, this is bullshit. There's something terrible going on, absolutely terrible going on in the United States. And we're exporting it to the rest of the world where we're saying these drugs are safe and effective. And we're just like, it's so freely given. The evidence base doesn't support it. And so I quit the pharmaceutical industry and I left, and my wife and I, we threw ourselves into our practice, and we're just like, we got to get people off this shit, because like there is a place for some psychiatric medication, but I think it's overdone by a factor of like 20. Like seriously, I think 5% of the people on drugs right now really need to be on them. I think the rest of them, it's totally overdone. And so now I just help people come off these drugs, and it's really hard. It's really hard to get people off these drugs. Anyway, so that might have been a little bit more than you asked for, but that's me in a nutshell.
No, I think that's perfect. And I think that's what people want to hear. Like, we need more doctors like yourself, because we have enough doctors, trying to put people on drugs. We don't have very many doctors trying to get people off drugs. And the people who are, trying to get people off drugs are not necessarily as qualified as you are. So, it's really important work that you're doing. And, I think, you made an amazing decision there. And I can imagine, when you do get these patients off drugs, it's probably very, very rewarding, for you. And I'm sure the patients, are very happy with yourself as well, So, I think the work you're doing is incredibly important. But, I do want to get into it, I guess, right away. So, the big one that I want to chat with you about today, the big class is antidepressants, and that seems to be probably the major one that you're trying to get people off of. We'll certainly chat about maybe some other drugs as well, but, antidepressants in particular, SSRI, selective serotonin reuptake inhibitors, and then SNRI, so serotonin, norepinephrine reuptake inhibitors. Those seem to be, the main classes of medications that people are taking for generalized anxiety disorder, depression, OCD, almost you name it. That's basically, first line. But when people are coming to you in your practice, like, what's the main reason why they're trying to get off of antidepressants? Is it because of one particular negative side effect, like sexual side effects, or what is the main reason overall?
So there's, unfortunately, a lot of the people that come to me have brain damage from the medications. And so there's a condition out there who most people will have never heard of, but it's massive. It's called protracted withdrawal. And it really happens when people try and come off antidepressants and benzodiazepines. These are sedatives. And if you come off those drugs too quickly, it just causes excitotoxicity in the brain, and they develop brain damage. They think they're in withdrawal, but they're not, because you put them back on the drugs and they don't get better. And so usually what happens is someone is, they're on medications for a long time, they're feeling fine, and they go, oh, it's time to come off, and they get tapered too quickly, or they do it on their own. And then they end up massively hurting themselves. And so they start, have ear ringing, light sensitivity. Some of them can be completely disabled. They develop paresthesias, like numbness in their hands and legs. And typically what happens when this happens to someone is the doctors say, oh, it's your underlying condition, it's getting worse, or, you're treatment resistant, or they'll even say you're like bipolar. And so these people, they'll be suffering immensely. They won't know what's going on to them. They feel like they're losing their mind because they have severe cognitive impairment and severe anxiety. And so they get nuked with drugs. And so they end up accumulating a lot of things. So a normal patient for me is someone who's got kind of a brain injury and is on a lot of drugs, and they want to come off. And so those are kind of my more serious people. And then I also get some folks who, there's probably two other people. I get really healthy people who are just like, hey, I've heard about protracted withdrawal, and I really don't want that. It's a really straightforward taper. Just like, get me off safely. I want to do it easy. And then we have, I know you're asking about antidepressants, but we also have some people who have schizophrenia and bipolar disorder, and they're really interested in the ketogenic diet research. And they say, I want to do a taper, but I want to use the ketogenic diet because I know that can be really helpful. And so I kind of have these three buckets of people, which I commonly treat.
Okay. And then in terms of like the specific SSRIs or the specific medicines, like, are there ones in particular that you find are worse than others? Like, say, do you think like, Paxil is worse than sertraline, or is Effexor worse than Cymbalta? Like, are there ones where you kind of see a patient and you're like, oh, wow, this is going to be tricky because they're on this particular medication?
Yeah. So I'll start with the easiest one. The best antidepressant is Wellbutrin. That one is really straightforward to taper. Anything stimulating like ADHD meds, they don't cause like brain damage when you come off of them. They're really pretty straightforward, and people tolerate. The tapers make them feel like lethargic and kind of lacking focus, but it's not like when you come off like your Prozac or your Paxil or stuff like that, where people develop severe anxiety and insomnia. And so really, like SSRIs, SNRIs, mirtazapine, they're all, I would say, one of the harder medications to come off. Within that group, I would say that Cymbalta, Paxil, Effexor, and mirtazapine tend to be pretty rough from what I've seen.
Yeah, that's those are you named Paxil and Effexor there. Those are the two ones I've, just kind of noticed anecdotally that patients find a really hard time getting off of. And I'll always remember the time when I was a resident when someone was trying to taper off and they told me that they had brain zaps. And immediately I kind of, very, very, naively thought that, God, this person, may be a little bit crazy or something. And then I went and told, my preceptor, and they said, yeah, like that can happen, And so that's a very, very odd, withdrawal effect to have. Like people literally are saying that like their brain feels like they're being zapped. Is that part of the withdrawal syndrome that you're talking about?
Yeah. They feel dizzy. They feel nauseous. They feel like their brain is, they gets jolted sometimes when they turn their head. They get these jolts. That's neurotoxicity. And the way I was always trained to think about it was, oh, this is just a mild and self-limiting withdrawal. And the truth is, it probably will be for like 90% of people, but there is a small group, like 10% of them, where that level of withdrawal actually becomes toxic. And so those signs people are having, that's sign that the brain is getting damaged. It's almost like a concussion. It's like you've been punched in the head. And some people they'll bounce back from it in a month, and they're just like they can take it in stride and recover. But other folks, they're injured for years afterwards. And question for you, Mike. I mean, did you ever hear about something called protracted withdrawal? Did it ever cross your radar, like in training or even recently?
No, not at all, ever. Like this is the first time that I'm hearing about it. Like I hear about, withdrawal symptoms, and I can certainly, list off, many of the withdrawal symptoms that people experience, like insomnia, irritability, brain zaps, lower cognition, fatigue, nausea, like all these kinds of things. But, in terms of like that particular term, it's not something that I ever heard about or learned in, medical school or residency. And so, I'm not ashamed to say that, but, I'm chatting with you today, so I'm learning about it. So it's fantastic. And, that's why, it's good to have conversations like this, because now everyone who hears this will know a little bit more about it.
Yeah. And you're not alone, because one of the biggest issues is that protracted withdrawal isn't even recognized in the drug labels for antidepressants. It's a big, I'll sound like I'm wearing like a tin hat right now, but to me, it's probably the biggest catastrophe that's happening to people right now in mental health that is not recognized. And if anyone here really wants to kind of, feel out the intensity of what this is, go to survivingantidepressants.org, and you will see hundreds of thousands of people all over the world who are struggling with this problem right now. And they're completely overlooked.
Yeah. And I mean, it's, obviously, if it's something that, I didn't learn about in school, I wonder, if it's even being taught now. I've been out of school now for over a decade, but, it certainly doesn't seem like it. Obviously you're shaking their head there. So, again, it's important to have these conversations so people can, learn about this syndrome, right? And in terms of, the syndrome itself and getting off of antidepressants, I always assume that, the longer you're on it and the higher dose you take, the harder it is to get off. Is that correct?
Yeah, it can be. Although I don't know if there's that much of a difference between 2 years and like 10 years. And there might be a ceiling of dependence, right? Like you take it for a good amount of time and then it's like, yeah, your brain's kind of like fully adapted here. And to me, like I look at it like a 2-year user the same as like a 10-year user or a 20-year user. And I mean, really what you're trying to do when you get the drug out, because the whole purpose of like doing a safe taper for someone is because you don't know who is going to be that 1 in 10 person who, you pull them off too quickly and you essentially cause brain damage to them. And so the way you mitigate that is you want to remove the drug in a way where the person never experiences a severe level of withdrawal. Like we don't want the world to be spinning. We don't want brain zaps. And so what that ends up looking like is typically a taper that might last 1 to 2 years. It's a lot it's a lot slower than a lot of people are taught. I was always taught you could probably do this in like 2 months max. And the real key to this is you can't do it on a time frame. You have to do it really flexibly with the person where you remove 10% 1 month. Yeah, I'm doing fine fine. You remove another 10%. And then when they say, okay, that was too much, you put them back and then you go to 5% reductions and you keep on going. You have to match it to the person's symptoms. And generally when you do that, you can get someone off within 2 years without causing them any harm.
So is the damage then that's done, like the brain damage that you're talking about, is that from taking the medication itself, or is it more from the tapering off and then getting the withdrawal effects that come along with it?
Yeah, so it's mostly from tapering off. So you have people, they're totally fine. And then they're like, oh, my doctor said I could get off in 2 months. And then they step off the last dose and then they feel terrible. And then they say, oh, I'm just going to hang on a little bit longer. My doctor keeps on saying it's going to go away. And it just gets worse and worse and worse. And then before you know it, they feel like, oh, I'm in a living hell. Like I can't think straight. I'm paralyzed with anxiety and my ears are ringing and my eyes hurt. And they go, what's going on? This isn't going away like they said. And they go, well, and then the doctor's like, oh, you're probably in withdrawal. And then they start the drug up again and nothing happens. They're just like stuck in this state of, brain damage essentially. And they're just like, what the hell has just happened to my life? And it can last for years.
Yeah. And in terms of the tapering itself, so, it's kind of difficult to taper like the way that you mentioned, so like from my understanding and from the, medications available in Canada, like let's say like escitalopram, which, at the max dose, I believe is 20 milligrams. Like if you wanted to taper off that, you kind of have to go from 20 to 15, like there's not like, it's very difficult to, go from, 20, say to 19, which would be, 5%, or even 20 to 18, which would be, 10%. So, do you have special formulations from a compound pharmacy that you use for these patients, or how do these patients taper, say, by 5 or 10%?
Yeah, so we almost always finish tapers with liquid formulations. So, just like you said, there's only so far you can get with the pre-manufactured tablets because they come in set increments. And sure, yeah, you can split tablets up with a pill splitter, but you can only split a tablet, reliably into about a quarter before it starts to have a lot of problems. And you actually need to be a lot more precise than that. So usually what I do is just you get the drug and you do 1 milligram to 1 ml liquid concentration, and then you use a syringe. And so instead of taking 20 milligrams of Lexapro a day, you take 20 mLs of that compounded solution, and you could get, and then you just use the syringe, and the syringe allows a lot of precision as you go down.
And so, is this something that any compound pharmacy can do, or is this something that it has to be like that, like just specific compound pharmacies could do? Yeah.
So this is something that any compounding pharmacy can do. the only drugs that can't be compounded in this way are, Cymbalta, Pristique, and Invega. But if you're not taking those drugs, all the other ones, any routine compounding pharmacy, you can make one of these formulations easily.
Okay. And in terms of, other reasons why people come off, we talked about the syndrome, but how about like the sexual dysfunction? Because a lot of people are, have that while they're on the drug, but then some people are saying that they have permanent effects from it. Is that something that you see with SSRIs? And is that another reason why a lot of people want to come off of antidepressants? Because I mean, when you think about it, it's like, someone's depressed, you put them on a medicine, and then all of a sudden, they can't, they don't have good sexual function anymore. Obviously, they're going to be even more depressed. So I think, a lot of people would probably be very, very concerned about this.
Yeah, that's a big reason why people want to come off. I mean, other big reasons would be like weight gain. A lot of people hate the weight gain and the metabolic problems, like you put on more weight. There's some blood sugar dysregulation as well, especially with mirtazapine. But also too. Another one. And with Seroquel, any antipsychotic is terrible for metabolic health. But the other thing as well, Mike, is that, the way these, for many years we were telling people, these drugs, they fix a chemical imbalance. There is no chemical imbalance. I mean, the way these drugs work is essentially they have a signature drug effect, which will be therapeutic for some people. With SSRI type antidepressants, they reduce anxiety a lot. They cause this kind of a blunting and separation from your emotions. And if you're someone who's constantly in a state of anxiety, you're going to experience that as therapeutic. But for some others, they're not going to like that. And that's another reason why people want to come off. They say things like, I don't feel like myself. I don't feel authentic. I feel like I'm faking my emotions. I don't feel anything when I hug a loved one. And so some people, they just don't like the way the drug actually makes them feel. They just go, I'll take the anxiety, thanks. And so there's a lot of effects just by being on the drug that people are just like, I just don't like the way this feels. But like you said, there is a very, very small group of people, but not insignificant, who when they get off these medications, their sexual functioning never returns. And these people were written off for a long time as just folks who were mistaking performance anxiety or for a drug side effect or they're just saying this because they have depression, and if you're depressed you're going to have low libido. That's been disproven now. I mean, this permanent sexual dysfunction is now in the drug labels in Australia, Canada, European Union. The FDA is investigating it at the moment. And this is just catastrophic, because one of the largest groups of people who get on these drugs, these are younger folks, teens, early 20s. And at least in the US, I don't know what it's like in Canada, but in the US, American Psychiatric Association guidelines say antidepressants are first-line treatment for depression and anxiety. You don't even have to do therapy before that. And so right now we're putting people on drugs where it's like a Russian roulette. You could get on it and be permanently sexually disabled for the rest of your life. And we think it's a first-line treatment. I mean, it is a rare side effect, but that's massively messed up. I mean, it's not worth the risk for a lot of people.
I agree. And I know that we've talked about SSRIs and SNRIs. Maybe we'll just briefly talk about some of the other classes as well. So, you mentioned just briefly Seroquel. The other one too it's not it is a classic antidepressant, but trazodone I find is prescribed a lot for sleep in Canada, as is Seroquel and as is mirtazapine. So trazodone and Seroquel, or quetiapine as it's called, those are prescribed for sleep in low doses generally, because they hit the antihistamine receptors, and people do find that it helps them sleep. But again, it may affect sleep architecture, but also too it can have dramatic effects on overall metabolic health. Like it can literally give you diabetes, to some degree. So those ones too, not a lot of people, but, there are many people anyway who take, SSRIs and then they take, Seroquel or antipsychotics on top of that. And so, do you find that a lot of people are also trying to get off these antipsychotic drugs as well?
Yeah. I mean, I look at a lot of the antipsychotics as, very, really potent drugs. I mean, they're kind of like the antidepressants in that they're very blunting, but they can also be very sedating. I mean, these are drugs that we use for people. I mean, they were developed for people with acute psychosis, with schizophrenia, who were really tormented by their thoughts, and we needed to just really turn the volume down on those. And so, a lot of people, they may not like feeling sedated and blunted. You'd mentioned, for me, giving antipsychotics to people who don't have very severe psychosis or who aren't in an acute manic episode is also something that I feel quite strongly about, because these drugs, they shrink your brain. I mean, if you look at the research around this, people who are given these medications, they have a good amount of brain shrinkage, which is seen on MRIs. And then when they've done animal studies, and they gave a bunch of macaque monkeys antipsychotics, and it shrunk their brain by about 10 to 15%. And sure, that
is it one
be
particular part, like the prefrontal cortex, the hippocampus, or is it just the entire
it's the
brain in general?
Yeah, no, it's the frontal lobe and the parietal lobe, which makes sense because it shuts off dopaminergic tone through the I think it's the mesocortical pathway in the brain, and so that area is going to atrophy. And so you get frontal and parietal, which is so frontal and then parietal right behind the frontal lobe as well. And on top of that, these drugs, they can cause permanent movement disorders like tardive dyskinesia. And so we have a big problem in the US. I don't know if you're having this in Canada, but we use a lot of Seroquel for insomnia at the moment because we want to get away from using benzos. Yeah. That's crazy. I mean, you're putting someone on a drug that can cause permanent neurological damage. I mean, it's much better if you're going to use something, to use mirtazapine or trazodone. I mean, to use Seroquel like that, it's crazy to me.
Yeah, well, I'm glad that you mentioned that, because it is heavily prescribed here in Canada as well. It seems like it's similar in the UK. The very last one that I want to touch on, I think there's only one drug within this class, but serotonin receptor modulators, so Trintellix or Viroxetine. What are your thoughts on that particular drug? Because I know that I had one psychiatrist on, and I don't want to say he pushed for it, but he said, there was, evidence that anyways, it can actually increase executive functioning and increase, cognition. But is that still something that you think, lies within the same danger zone as SSRIs and SNRIs? And do people still have, the exact same sort of side effects when tapering off?
Yeah, so I mean, what I would say is he's probably right, that there is something different happening at the receptor level when you take it, and it may be a more stimulating drug just with how it hits the different receptors, and you may feel more focused. But ultimately, the problem with long-term psychiatric medication use for all of them is that your brain doesn't like it. I mean, these neurochemicals, they're involved in the physiology of the whole body. They're involved in how your gut works and how your heart beats. And when you start to modulate them, homeostatic factors in the body kick in, and then they down-regulate the receptors that the drugs are acting upon, and you develop kind of a tolerance to it over time. And so you end up essentially in this trap where maybe it works great for the first year to 18 months, but then you need a higher dose, and then you need a higher dose. And then also, we don't really know that much about what happens to these folks long term. But here's another word, that another side effect which no one's ever told about is the side effect of tardive dysphoria, which is essentially a state of lethargy and low motivation, anxiety and agitation that can be induced by the drugs. And so some people, when they take these drugs long term, it's done something to the brain where they just never feel quite right again. And you can give them all the drugs that you want. You can give them like antipsychotics. You could do procedures like ECT, and they just don't respond to anything. And doctors will say, these people are treatment resistant at that point. You have treatment resistant depression. But really, what I think is going on with these folks is their brains have changed from just being on the medications for so long. And so, whether it's Trintellix or Prozac, the older one, I think we are running into the same risks with all of these drugs in the long run. With one exception, what I will say is from doing this for a long time, I don't see a lot of problems with stimulants or Wellbutrin. I don't know what it is. The stimulating drugs, they just don't seem to be causing the same amount of damage as the sedatives and the ones that blunt long term.
Interesting. And Wellbutrin, that would be an NDRI, is that correct? Norepinephrine dopamine reuptake inhibitor. So, okay, interesting. So so it seems like more like the serotonin drugs are the ones that have the most side effects and are the most difficult to get off of overall. Yeah,
that's true.
And then the other thing that sort of, is very unfortunate too, like I don't know, how what your thoughts are really on, psychedelics and psychedelic-assisted psychotherapy, but it seems like when you're on these medicines and then, you take psychedelics, that there's a blunted effect. People don't get the same effect, which is unfortunate because, I know we need more trials, but still, I mean, there's a meta-analysis came out actually just a few days ago on psilocybin assisted psychotherapy, indicating that it had, tremendous effects overall. There's still more and more studies that need to be done on MDMA, but, I do think that these, drugs in the right context, certainly not every day. Like I'm talking like, once every 3 months, maybe the microdosing thing will, turn out to be effective as well. There was that one study where they compared it to escitalopram and it seemed to be pretty effective in the New England Journal of Medicine. But seems like if you're on antidepressants, unfortunately, you won't get the same, benefits as these drugs as well. So that's sort of, not necessarily a side effect, but just another reason to maybe, think about what you're doing before you start these drugs, because that maybe not be an option for you like it would if you had not taken those particular drugs. I'm not sure if anyone in your practice has, asked you about that. And then, you've had to tell them like, listen, like, you're on this medicine and, first of all, it may be dangerous to take them both at the same time. And then second of all, because it could cause, serotonin syndrome. But then also too, you may just not get the actual therapeutic beneficial effect that you would if you were not on these drugs. Yeah.
So, I mean, what I would say about that is there's a couple of things that stick out to me. Yeah, I think it does make sense. Like, yes, if you're taking very serotonergic drugs and then you're using things like MDMA or psilocybin, you may have kind of disrupted your serotonin system a little bit and you're not going to experience that same level of effect from it. I mean, that makes sense to me. But the last station that I did in the pharmaceutical industry before I left for good was actually in a psychedelic company called Usona, and they were developing psilocybin for MDMA at the time. And when I was reviewing the research across all of the different companies who were doing this, they actually do, like the pharmaceutical companies do have arms in their clinical trials where they won't bring people off the medications and they'll just leave them on the drugs, on their SSRIs or whatever, and then give them the psilocybin, even though, there is this risk of serotonin syndrome, and it still works. I mean, that was what I remembered at that time. Yes, it could be muted, but it still works. So
that's good news.
Yeah. So so yes, there is a risk of serotonin syndrome, and you'd want to be aware of that. But I think the biggest thing that I'm worried about with whether it's MDMA, psilocybin, ayahuasca, ibogaine, is a lot of people get told, yeah, you should come off these medications before you do this treatment. And oftentimes the people will be very excited about doing the treatment and then they'll rush off and they'll hurt themselves. or they'll, destabilize their nervous system because they've gone off too quickly. Their nervous system's super brittle. Maybe they're still having some withdrawal symptoms. It's almost like you've had a concussion sometimes coming off these, and then they will expose their brittle nervous system to, a powerful psychedelic drug, and it can hurt them. It can cause neurotoxicity. So my message to anyone listening to this who wants to do it, if you really need to do it, talk to the doctor and maybe just consider staying on the drug. Don't rush off of it. If you want to come off your antidepressant and do it without it, make sure you give yourself, up to a year or maybe even longer to do it. You certainly don't want to rush off it and hurt yourself.
Well, there's a couple really good points you made there. One is, it's good to know that, there's clinical trials that indicate that, people can still have, the beneficial effects, while they're on the drug. And then the second thing, obviously, you mentioned is probably even more, helpful, or something that, people need to hear even more, is that, don't rush off the drug, because, you could end up hurting yourself to some degree. So, I think those are both really important points that you just made. So I appreciate that. One thing I want to talk about with regard to the tapering. So we talked about, if you can, certainly try to taper very, very slowly, don't go from 20 milligrams to 15 milligrams. If you can, try to go from 20, say, to 19 or 18, 5 or 10% as more to say 25% at a time. But when people are coming off, besides say like exercise or some of the obvious things, are there any things that you suggest, any supplements or any specific behavioral techniques that people can use, maybe minimize the withdrawal effects or to have better success overall with just tapering off?
Yeah, so I'm pretty simple when it comes to this stuff. We've looked at a lot of supplements and things like that, and I'm not seeing any clear patterns. Some people say magnesium helps for anxiety. That seems to be a big one, but that can be hit and miss. What I like to think is that you don't want to put yourself into a position where you're like, man, I really need to take something to manage this withdrawal. You're kind of going too fast at that point. Ideally, what a good drug taper looks like is mild withdrawal symptoms at most, not anything that impacts your ability to do your job or look after your home. And so the best thing is, to go slow. And then on top of that, it's just looking after your general health. I'm a strong believer that what I think is totally overlooked is actually exercise. If you can just do a bit of exercise and move your body, I actually think it's like we are totally designed to need exercise to actually regulate our mood. And so to the extent that you can, to try and do some exercise every day is really important. And then eating clean. And I think if you're eating clean and you're doing exercise, from my perspective, you're most of the way there. Everything else is just kind of tweaking, but those are the biggest blocks. Is
there any particular diet that you recommend when people are tapering off?
I recommend a paleo style diet. One, because it removes a lot of food sensitivities. And so if you're having problems with gluten or soy, it's going to get rid of that. But also with a paleo style diet, you remove processed foods. And so you go down on seed oils a lot, and preservatives and all the other shit that's in that stuff. And so I think eliminating those things tend to make a lot of people feel better. And so I'd start there. Some people have a lot of benefit from doing a ketogenic diet, but it's a much larger undertaking. So usually we just put everyone on a paleo style diet first.
How about CBD oil? Have any of your patients ever had any success with that?
Some people have said it's been helpful, but not really. Mostly, to tell you kind of a bit more about my philosophy, is I'm sort of I tell people, I think the ideal place for the brain to heal, because that's what we're talking about with a withdrawal, is let's get as much out as possible. Let's just kind of go back to the basics, just exercise, good food. And I don't really recommend too many other things. I'm okay with it if people are like, hey, this really helps for me. I'm like, go for it. Just keep me in the loop. But it's not something that I'm promoting or really even paying that close attention to. Yeah.
And if they do, probably not more than one thing at a time, certainly not more than one thing every 2 to 4 weeks, because then you just don't really know what's working and what's not. like in terms of like if you're going to introduce something.
Yep. Okay. For sure. On an unrelated note, because I know you're into biohacking and things like that, not related to tapering, lithium orotate. Have you experimented with lithium orotate before?
Yeah. 5 milligrams, and even 1 or 2 milligrams. Yeah. That's impressive. That one really took me by surprise, because I've tried like a lot of different supplements. As someone who runs kind of anxious and irritable, like and kind of snappy and restless, like it is kind of, especially at the end of a long day, lithium orotate is crazy. And also taking it just before I go out to socialize, it puts me in such a better state of mind. And so shout out to lithium orotate, 5 milligrams. If you're anxious or irritable, that's a pretty safe intervention that can make you feel great. And for people who are listening to, like, 5 milligrams is such a low dose. Like when people are taking it for bipolar disease, like true bipolar disease, like they're taking like 2,000-ish milligrams. It's not lithium orotate; it's a different form, but like it's a crazy amount that they're taking. Correct?
Yeah. So lithium carbonate. So the starting dose for bipolar would be around 900 of lithium carbonate. Now, lithium carbonate, the carbonate form compared to the orotate form is 3 times more concentrated. So essentially, like if you took like lithium orotate and it was like, so essentially like 3 of carbonate would be like 1 of orotate. So if you're taking, let's say you take 10, let's say you're taking okay, so let's say a dose is like, let's just say a dose is like 5 milligrams of orotate. Like that's like almost like 2 milligrams of carbonate. And so it's essentially like you would be taking 2 milligrams of carbonate compared to like 900 milligrams of carbonate, which would be the bipolar dose. So it's just, it's like it's nutritional at that level. And my understanding of how they pick the amount is that there's all of these studies out there that show that in the areas around the world that have high lithium deposits to the extent that it actually enters the water supply, they've found things like the people will, they'll have less anxiety and less depression and lower suicide rates in those areas where there's a lot of lithium. And when you're taking lithium orotate in these low doses, 2 milligrams, something like that, 2 to 3 milligrams, that's kind of just like mimicking what some people are just getting out of their groundwater. And so, taking around 2 to 3 milligrams is like nothing. It's really a nutritional level. You start to notice a bit more of an effect at 5 and a pretty noticeable one at 10. It's nothing crazy, but it's still, I mean, we're talking trace amounts of lithium. It's pretty cool.
Yeah, no, I'm glad that you mentioned that. I think that could, certainly help, a lot of people. And I know I only got you there for, another 5 or 8 minutes there. So I just wanted to get through maybe a couple quick things. I know we've touched on ADHD meds, and you've said that, in general, they seem to be less harmful, easier to taper off of than, SSRIs, SNRIs, or classic, antidepressants. In terms of the taper, though, again, it's sort of the same issue. Like if you look at, anyways, in Canada, like Concerta or the other big one, Vyvanse, those 2 medicines, they come generally in increments of 10 anyway, is Vyvanse. Concerta, I think, is in increments of 9. So, you're going from like 36 milligrams to 27 milligrams. In your practice, do you also, employ the same technique to those medicines as you do to the SSRIs, or? Okay.
We don't use any liquids for heavy stimulants, which would be Ritalin and amphetamine salts and things like that. You can just go down to the lower size and jump off. Now, people will they'll have sedation, they'll have brain fog, but it will get better. And so they're quite safe to just taper off using the manufactured forms. Sometimes with Wellbutrin, we will still use a liquid, even though it's very safe. But honestly, with Wellbutrin, you could probably do the whole thing if you just quartered the tablets when you got low.
And when you're doing the taper, you're not at risk of brain toxicity or neurotoxicity. Is that correct? Okay. So
Yeah,
you will
I've
experience the
never seen
withdrawal
it.
effects,
Yeah,
but you're not
yeah,
going to put yourself at risk of brain injury. And just
correct.
one kind of note too, like on that brain injury note, like would that be different than say like what happens when people get a brain injury from like trauma, like from like a concussion? Or is it, quite different, or is it something specific more or less to like the drugs itself?
In some ways similar, in some ways different, right? Like let's say you had like a coup contra coup, like sort of, you got rear-ended in a car crash and you went forward and you smacked your head really hard, and then the brain hit the back, and it might be localized to the frontal lobe and the occipital lobes, just based on like kind of that impact. But with one of these injuries, what we find are the most, like these drug injuries, the most classic symptoms then, it's kind of more global disruption rather than localized. So you get ear ringing, light sensitivity, severe anxiety, cognitive dysfunction, GI problems as well. A lot of people have like constipation and bloating, and then they have paresthesias. So it really sort of has this sort of global neurological dysfunction flair to it, with the most common thing is the heavy anxiety and cognitive impairment. That's like the kind of the symptom that overshadows all of the other things. But where they're similar is really in how they behave over time, right? So both of these things, both head injuries and these protracted withdrawal injuries, tend towards improvement, especially if you've only had one of them. It's sometimes in the course of 1 to 2 years, and people gradually get better. And a lot of them will have a full recovery or a near full recovery. The prognosis is pretty good. But if you keep on getting these injuries, kind of like that football player who keeps on getting concussions, it can become permanent. The same thing with these drug injuries. If you do a withdrawal, then you get back on the drug, and then you do an abrupt one, and then maybe you get put on a drug at too high of a dose, or you go and you do a psilocybin trip or something that's really excitatory to the brain when it's already in this brittle state, you can hurt yourself pretty badly. And then those injuries take a lot longer to recover from. So in that way, I'd say they're kind of similar in sort of the clinical course, but the symptoms at the start can be very different.
What about caffeine withdrawal? Is there any issues with that? Can that cause any neurotoxicity, any issues? No. Okay.
From what I've seen, coming off stimulants, it puts the brain into a very depressed state, and that's not harmful. You feel like lethargic, very like GABA heavy state. But if you come off drugs that depress the brain, like benzos, the like sedatives, things that reduce anxiety, it's very excitatory. After in the brain, there's like a lot of anxiety and things, and there must be something about that highly excitatory state that's actually neurotoxic. I mean, because that's the only way it makes sense to me that the actual sedatives and the anxiety reducing drugs are causing a lot of these brain injuries. And I'm not seeing it in people coming off stimulants at all.
Okay. Well, it's good to know at least, one class of medications is, easier to come off of. So, I know our time is up there today, but you've got a very popular YouTube channel. You're also very popular on Instagram. Can you just let people know where they can learn more about yourself, where they can learn more about your clinic and what you're doing?
Sure. So yeah, the YouTube page is probably the best place. So that's Dr. Yosef, but you spell it in the German way. So it's Josef, not PH. And then if you want to see our website, we're in 10 different states in the US, most of the most populous ones like California and New York and such. And that is the taperclinic.com. And you'll find all, I mean, we're on TikTok, Insta, X, and links are all over my website and the YouTube page. If, pick the platform of your choice, we're there.
That's awesome. Actually, yeah. I've been listening to DJ Tomic, that song Ich Lebe für Hip Hop he did with Jizza. I don't know if you know that one. It's like 15 years old now, but it's a wicked song. I'll have to send it to you.
Yeah, do it.
Anyways. Yeah. Thank you so much for coming on, brother. You definitely helped out. I think a lot of people today. I certainly learned a lot, so I'm sure everyone listening did too. In some time, Michelle, I'd love to have you back on the show because again, we got through a lot of information today. We didn't quite get to the insomnia stuff, but still, the antidepressants, the ADHD meds. It's been awesome. So it was a pleasure to have you on, and thank you so much, everyone, for listening. And as always, I'll be back again with another episode soon.